Assalamualaikum, everyone. Welcome to this month's Institute of Mental Health Meet the Expert webinar series. Alhamdulillah, this month our speaker is Dr. Mohamed Elsamra. He's worked as a medical director at Turnbridge, New Haven, Connecticut. He has 15 years of experience in the field and believes in using new approaches, including technology, to overcome the suffering of millions with stress, anxiety, and addiction. He has experience in managing diverse clinical and administrative teams to serve individuals with mental health issues. He also founded Meditox Care for outpatient detox to help people to get a faster drug detoxification in Connecticut. So welcome to today's talk on It's All in Our Head with Dr. Mohamed Elsamra.
Assalamu alaikum. Thank you, Dr. Wafa Atiyah. And thank you for inviting me, Dr. Hamada, and all the wonderful staff in Muslim mental health. So the talk today, it's hard to think of a title, but I think people in mental health, including myself, are known to be a little choosing a very careful approaches in making titles and pictures and sharing things. So given the very the statement that I've been hearing more and more from my patients, it must be in my head, doctor. So I really felt that that's such an interesting title, especially when we talk about anxiety, fears, and trauma. Um, so hence that title. So today I have almost 12, 13 slides I want to share with you. Most of the information are something we all know. However, my objective of this seminar or this talk is really to kind of pinpoint the connection between the mood disorders in general, but specifically the anxiety disorder with the how our body react physiologically to them. And we know that we talk about it, but at the time of actually making our treatment plans, I feel like even after all these years, we tend to kind of underestimate the impact of the physiological symptoms of these disorders on our body. Just as a background, as we know, there's over 40 million individuals in the United States going to suffer from anxiety disorder. And again, anxiety, the umbrella of anxiety disorder are pretty vast. It could be generalized anxiety, panic attacks, PTSD, and everything else. And according to the statistics, really almost 40% of people with anxiety, depression, and addiction were not able to get the appropriate care, whether they live in areas that are not covered well, or that when they get the care, they really not able to kind of get the complete treatment that they need. This is so important to understand also the magnitude of, I want to say, sometimes dysfunction of our mental health care in our system. So that's important for us to understand. Um, so the objectives is understanding anxiety disorders, the impact of fear on our body, and that the emotional aspect is always connected with the physiological aspect. And I want to give a trauma-induced anxiety or PTSD, use that as a model and as an example. And then after that, I want to talk about some treatment options in terms of medications. And at the end, I'll open it to questions and answers. Feel free to send your questions to Dr. Wafat and the organizers, and kind of at the end, she will go through the questions and we can have an open discussion, inshallah. All right, so if I want to guess, anxiety or being stressed or being anxious is one of the most common words that we use in our daily life, whether children, teens, and adults. But the important distinction between having anxiety, stress, fear versus the anxiety disorder as a mental illness is that the fear or the anxiety, the healthy one, is very short term and very stimulus specific. So we have a test, we have a game, we have a stressful situation at work, we get anxious, very short term, and once that stimulus is removed, then we back to normal, right? Again, we all heard about the role of amygdala in all these uh, circuits, and in this case, it's there too. So the amygdala is that responsive body part that we have that react appropriately to any stimulus. Um, but once the anxiety or the fear start to be more long-term um, and the sustained response and start to affect our behaviors, then we start to call it anxiety disorder. So now the stimulus is removed, the test is over, the meeting happened yesterday, but our body and our mind are still reacting intensely. And that's when we start to have that the amygdala here, through especially the area that projections to the stria terminalis, is that's when they are kind of responsible for this kind of long-term effect of the anxiety symptoms. So in a more kind of complicated way of describing anxiety, it's that feeling of the fear and the physiological expression of the fear that lasts longer after the stimulus was removed. So that's really the feeling or the anxious feeling that we have that we can't explain why do we have. Um, so the mental component of anxiety that we kind of all know what our anxiety symptoms are, but the three systems that are affected very much because of that is the cardiovascular system, the endocrine system, and the lungs or the respiratory system. Um, so the cardiovascular system and the amygdala, through the effect on the locus coeruleus, it affect really the autonomic nervous system. So it affects the things that we cannot control, right? So it increases the heart rate, increases the blood pressure, and there's an increased risk of ischemic heart disease, myocardial infarction, and actually sudden death. And that's so interesting that um, this is not a secret that we understand how during the panic attack or the anxiety attacks, our heart rate is up, our blood pressure is high. However, when people have chronic anxiety, this system is affected long term and actually put the individual at risk of heart disease and sudden. So that's the effect that one of the effect on the heart system or cardiovascular system. Um, the endocrine system, and we all know this axis, HPA axis, which affect our pituitary gland and hypothalamus, which affect a lot of hormones in our body. Uh, Through this axis, there's more glucocorticoids secretions in our body, it increases the cortisone, increases from the adrenal glands, and we see a lot of weight gain during anxiety disorders. We see increased risk of type 2 diabetes, increased risk of stroke as well. The third system, which we see also pretty often during panic attacks, but also through the chronic anxiety, is the effect of anxiety on the parabrachial nucleus, which affects the breathing, how we breathe, how we feel. The people with anxiety, their chests are tight, and it can actually put them at risk of having an asthma attack. Um, a lot of these symptoms we see it in panic attacks, but also it can have long-term complications. So these are the main three systems that fears or the constant stimuli that causes the anxiety can be affected by. Um, feel like, was there any questions or any follow-up uh, questions or comments, Dr. Wafat, from your end?
Someone asked, sorry, I missed the first system. What was it?
Cardiovascular or heart system, the cardiac system here.
And that was all that I got.
Okay, sorry.
Oh, someone else just asked, what is the connection between thyroid and motor disorder risk
And mono, I'm sorry.
and mood disorder risk? Was it
Oh,
type?
okay. Okay. So what happened is the the amygdala that controls our experiences and our memory of fears and anxiety, it affects the whole hormonal system. So, and it affects them through increasing the glucocorticoids and increasing the cortisol. And when when our body has increased level of cortisol and glucocorticoids, then the endocrine system is affected by stopping producing these hormones. And that's why we are susceptible to weight gain, we're susceptible to type 2 diabetes, and we're susceptible to stroke. The thyroid is a key component of that system. So it can happen, so it's like the chicken or the egg. So increase the thyroid stimulating hormone can increase the thyroid hormones, which can cause anxiety. But also, people with anxiety, through the increased hormonal excretions, increased cortisols, can tell the hypothalamus, hey, stop producing thyroid stimulating hormones because we have a lot of it. So actually they stop. So that can put people at risk of hypothyroidism. And that's why hypothyroidism, or the decreased the function of the thyroid gland, we see it a lot connected with depression and feeling tired and feeling fatigued. However, the increased the thyroid hormones can make people more anxious and jittery and restless.
There was a comment that said immune system effects probably modulated through endocrine system.
Mm-hmm. Yeah, that's definitely modulated through it can affect the immune system as well. Okay. Um, so the main example that I want to give today is that anxiety that is not triggered only by the external stimuli, but the anxiety that is triggered by the internal stimuli. In this case, the memories, the traumatic memories that is stored in the hippocampus, right? So in this case, the anxiety is not about what we see, what we face, who we meet, and what are the social situations that we're in at that day, but because of our memories, because of our traumatic memories. And the hippocampus here is almost that hard drive that saves these traumatic memories and make people relive them. And when the amygdala sends that response, so the amygdala does the same thing over and over again. So really, that is the trauma-induced anxiety, or what we call PTSD, right? Which means that the body here is responding to repeated internal stimuli from the memories that is stored in our hippocampus. And again, it's very connected through circuits, but it's complicated because it happens sometimes more often than not. But once it starts to happen more often, then the firing of these circuits can affect our patients on a daily basis. Okay, so again, the axis here, or the circuit, is that the memory which stored from the traumatic event in the hippocampus stimulate the amygdala again, and we all know the connection with the amygdala with creating that physiological reaction again to fear in the form of anxiety. Okay, and that is PTSD as a disorder. There's a couple of terms here that, and we go back again to a PTSD. There's a very interesting table that I tried to take a picture of from Stahl's that I found very interesting about PTSD. But two terms here that we use a lot, which is the fear conditioning and the stress sensitization. Most of the time, the fear conditioning it's kind of the normal response to the amygdala, right? When there is a uh, uh, to to respond to the fear stimuli, so it can react better the next time. So again, the amygdala wants to react better. I was in a situation in a storm. I don't want to deal with that again. So I want to keep that reaction. I want to sense these stimuli and I want to react better. So that's the fear conditioning. The body, the healthy body does that. But when the stress is constant, especially in the cases of abuse, especially during children, in these cases, the circuits start to unable to relax in between these conditioning. So instead of reaching the comfort state in between the anxiety feeling. In this case, the body is really remain overly active. And because of the chronic nature of the stress or the abuse. So these are two um, um, things that we always discuss in our meetings, but there's this very distinctive difference in their meanings. Um, okay. Um, to pick up on that, chronic stress and trauma during childhood, the big question is all stress bad in childhood or for children? Usually the answer is no. Uh, so if there's no stress, their body react healthy and their reactions are healthy and stable. But when there is a mild stress in their life, they actually are able to produce reactions that are kind of can help them, right? And increase the reactions, but they have the ability to control in between those stressful situations. And to go back, they will be able to build really fear conditioning. So their amygdala, as a response, was able to kind of understand these stimuli, make it control of the situation, and prepare better in the next situation. But when there's a chronic stress, as we said, it gets children into the stress sensitization, and they usually liable increased risk of anxiety and depression at older age. Um, in the past few years, we've been using a lot of the word PTSD. We use it in our daily lives, but one of the things that I know you will not be able to see this table, but I have the book here. Which is the type of the trauma and and the PTSD. So, and they separating the type of trauma between men and women. And you don't have to put effort here to try to read it, but it's very interesting because um, there's a difference between men and women of how to handle different types of trauma. For example, let's start with men. So witnessing violence for men is common. It's actually one of the most common trauma that, and this is it, witnessing violence. But it's usually most of the time it doesn't cause PTSD. And this is, statistics that are really published by the recent Stahl's book. Uh, Being in an accident or witnessing an accident. This is also the number two lifetime prevalence in the list of lifetime prevalence for men. Again, this is usually a situation that not commonly causes PTSD. A threat with a weapon. I would thought that would cause a PTSD. I mean, obviously, this is statistic that just some people can, but it says here in the book, in the comment, actually, only 12% of people who threaten with a weapon can have PTSD in men. Okay. Natural disasters is the fourth in how often that men face traumatic events, and again, not commonly causing PTSD. Uh, After that, combat, obviously, high risk of PTSD, childhood and physical and emotional abuse that can cause PTSD, or more commonly causing PSD, sexual molestation, or childhood neglect, which is very interesting. So things like that was interesting information for me. So things like childhood neglect would have high risk of PTSD than witnessing a trauma or being in an accident, which is again for us to reflect. Right. Let's go to the women's table. I think there's some similarities, which is the natural disaster, which is the most common trauma that face women, I guess, here, and it doesn't usually have um, a tendency to cause PTSD. Witnessing an accident or witnessing a violent event is also common for women, and it not seems like it doesn't have tendency to cause PTSD. Accident is the same like men. It doesn't cause PTSD. Uh, Followed by molestation and sexual rape at high. So this is higher in a risk than men. It's here lower in risk, but women faces this more. Obviously, it can cause PTSD, physical attack, does cause PTSD. Threat with a weapon, which is so interestingly different than men. So although it's lower in the risk, but it has more risk of causing PTSD in women. Childhood abuse and childhood neglect can cause PTSD. That table I wanted to share really, it was a cool thing to understand. Another factor here, or another physiological reaction that is really to that traumatic event, and I again stole that from Dr. Stahl's books, which I like that kind of these funny things, is the pain. So we talked about the heart, we talked about the endocrine system, we talked about the breathing or the lungs, but also the pain. So this is still theoretical, and they're trying to do some studies to see that connection. So, but in a nutshell, is when when an event or a traumatic event that associated with pain happen, right? Let me just load the study. Yeah. So the emotional consequence or the PTSD, the emotional symptoms in the future when that client or when that patient start to struggle with them, it actually put him back and feeling the physical pain that can caused by that accident or was caused by the accident, and vice versa. If that person faces any painful stimuli in the future, it actually connects that person with reliving that traumatic event, which is very interesting that um, although the physical pain here is very separated and that person's pain may be gone and treated very well. However, any revisiting to that traumatic events or these symptoms can actually put that person back into feeling that physical pain. So that's again a very interesting connection with the emotional impact of the trauma. Uh, so treatment. Um, and I want to wrap everything what I talked about here in that slide because that's really what I feel like if there's a take home message would be how we handle or how we treat these people as much as good as we can. So the therapy, the CBT, the SIT, and EMDR, these are just forms of therapy that is really meant to treat anxiety in general and PTSD. Um, in terms of medication, I always tell people I work with, we treat the emotions, we treat the mood disorder, but we have to treat the physiological reactions. We have to treat the pain, we have to treat the insomnia, we have to treat the heart rate, we have to measure the blood pressure and treat it. We have to get labs for the endocrine system and monitor them. And we really have to believe in it and not only say it, but we have to get these labs and we have to see if we're able to treat the mood disorder well with medications, the usual SSRI and SNRI and mood stabilizers, are the lab values are going back to normal. We should actually track them that way. I know that there's no solid evidence that there's a specific increase of cortisone in the blood that can show whether that person is suffering from clinical symptoms or not. But what I'm saying is it's hard to um, ignore the physiological impact of anxiety and trauma and mood disorder. One of the medications that I use a lot with people with anxiety and trauma is really gabapentin and Lyrica. Although Lyrica is as a scheduled medications and geared more towards neuropathic pain, but I can't tell you how much when I sometimes feel like I start with gabapentin, and when I get a partial response, I really switch it to Lyrica, and that way I really feel I usually get a better response from the gabapentin, and these medications are add-on on the main treatment of SSRI or SNRI, like Prozac, Zoloft, Lexapro, and all these medications. But adding alpha-2 agents are so important. Alpha-2 antagonists or medications like clonidine or similarly guanfacine are very important to treat anxiety and very important to treat the autonomic nervous system, which is helping the heart rate, helping the blood pressure, and helping that physiological reaction that happens during the physical attack of the anxiety or in the baseline. Benzodiazepines, I understand in our field sometimes they're frowned upon. I use them pretty often, especially the long-acting benzo or the long-acting benzodiazepines like Valium or Klonopin. They're very helpful. I think especially with people with trauma, um, there's nothing more hard for them to come to seek help and to seek medication management. And we still insist um, not to give them something to help them at that time. We have to rule out substance use disorders. We have to rule out misuse of these medications. However, when people are really struggling with trauma, we need to give them relief. Again, and these are as an add-on to the SSRIs. New ideas is and that's we do that sometimes. Can PTSD be preventable? So there's a lot of direction now when people they started in the 90s from the Gulf War, where combat veterans came back and they give them beta blocker, they give them clonidine in order to go back that slide of the amygdala affecting different areas of the heart and the brain. So giving them beta blockers to actually prevent these circuits from getting initiated, that sensory sensitization that we talked about. So medication like beta blocker after car accidents, after an accident of rape, if our clients start to report the trauma or report the accidents to us, then we have to actually kind of preemptively uh, ask the people who are the med providers to actually try to maybe initiate beta blockers um, right after the trauma. Administering hydrocortisone is also an interesting new concept. I didn't do that honestly, but one of the very interesting thing is when they found the susceptibility to have a PTSD, they found that people who have they compared two groups. A group of people faced the trauma with a lower hydrocortisone level, and another group faced the trauma with a high level of hydrocortisone level. So actually, people with have a healthy hydrocortisone level have less susceptibility to have PTSD. So again, these are the new concept of having once we have a traumatic event, maybe we can check their labs and maybe we can treat them with oral hydrocortisone. Small doses usually recommended. Uh, uh, Ganaxolone is a medication I've never tried, but it seems like it was asked Dr. Hamada. It was approved for seizure disorder, but I think there's a lot of also um, um, trying to study the effect of especially anxiety disorder in general, and especially the trauma-related anxiety. Um, or I think this was my last slide. But again, I feel like I want to go back to these medications again, the beta blocker, the hydrocortisone, and all these medications. The main goal is really to treat these symptoms. Um, the effect of the amygdala on the heart rate, blood pressure, effect to prevent the risk of ischemic heart disease in these cases as well, the endocrine system, get the labs, treat the hormonal abnormalities, treat them very well. And then the breathing component, which usually can happen a lot of work in therapy on how to regulate the breathing and the breathing exercise, but also people with asthma tend to benefit a lot from um, regulating their breathing with inhalers actually before once they start to feel the panic attacks. That's something I usually tell my patients, all right, this get the inhaler ready, have the inhaler in your bag. It's almost like have the Klonopin in your flight and have the inhaler in your flight as well to kind of regulate the breathing before the full-blown asthma panic attack. And then we talked about the pain, and I think that was my last slide. Resources for our patient. I love this website at the mayoclinic.org. They have a very amazing library that I recommend it to patients. They get the symptoms, they get the treatment, they get the direction, they get very nice classification of mental illness and dosage of medication. It's a very nice website that I really recommend that you pass to your clients if you're interested to. And I think that will be it. I think we did it 25 minutes, even 30 minutes, right? With that.
Yes, Jazakumullah khair. Thank you so much. So we do have some questions that came into the chat. We can also open up the floor. So I'll ask one from the chat, and then if anyone has one from the audience, and we can go back and forth in that way.
Yeah, I think that's a good idea.
So the first question I have is, when do you diagnose PTSD following a trauma event?
Um, I work in an outpatient clinic, and we kind of sometimes we pretend to care about the DSM-5, but I would say usually go with the DSM-5 criteria. Um, m- if after 1 month I feel comfortable of diagnosing it, um, uh, so in terms of times and in terms of period, I usually wait for a month. Um, some people wait for 6 months to diagnosis to put it as a documented PTSD. But the most important thing is I really go clinical. I really like to see different sets of different group of symptoms, right? The trauma and how did it affect the mood disorder and how that person is really reliving these traumatic events over and over and over. And when that happens more than a month, then I feel comfortable of diagnosing PTSD, a post-traumatic stress disorder.
Jazakumullah khair. Does anyone in the audience have a question that they'd like to ask?
Or a case, an interesting case that you want to share without graphic details, obviously, but just like to help with this discussion.
As people keep coming up with their ideas. So, Dr. Mohammed, can you comment about the balance of therapy versus treatment? There, I mean, at least when I was in training, there was kind of the feeling of, that you for more mild anxiety, that you try to avoid medication, especially benzos, to give therapy a chance, because if you overtreat, especially with benzos, you don't let people use therapy to rewire those networks and try to empower them to handle it without medication.
Yeah, I like that question. It was very interesting that um, I probably I'm more aggressive with medication, especially when it's PTSD, because these people struggling a lot, and I feel once you start to feel the pain, and once you start to feel the the the, the events and the helplessness, right? The trauma equals helplessness, and when they come to visit you, the last thing you want to make them again helpless to get the right treatment. But therapy, I believe in therapy more now than before, especially working with people who are like savvy in applying these EMDR techniques, right? And I do believe that using benzodiazepine has to be also used with a dose that is so careful. The last thing I want to do is just block his symptoms 24/7 all the time. What I would not understand the progress of my treatment if I do that, and I would not understand the progress of the therapy treatment. So I usually start very small doses that once a day. Ideally, the first 2 visits I said, take it as needed, maybe 3, 4 times a week, but and we'll go from there. So I can allow the time for the medications like SSI to work. Therapy is a huge component of the trauma uh, 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 because they provide the support first. We control the symptoms second, and then if they do want to dig in a deeper way of handling those trauma and the memories of the trauma through EMDR, then we go there. I feel I like initially to start with a supportive therapy, and I believe that people who have been doing EMDR in my office do usually take time to understand the story, understand the patient, understand their reactions, and also understand and building how when they relive these experiences through the eye movements, they're able to kind of hold that person back by the end of the session or that week, instead of just activating their amygdala, but not able to contain it. So I, I, I think it's amazing. And it's when it's done well with experienced therapists, it gives us great results. There was, I'm sure you read those studies of adding cycloserine to the therapy. I remember reading studies they added before and sometimes after. I used to do, I did that during my residency and after, but I honestly, I didn't do it recently. NAC or NAC, as much as it helps with the, I think, cannabis use. I did read a couple of studies that it can be combined with therapy as well for people with anxiety. I'm not quite sure if we've done it, but yeah, they go hand in hand. Obviously, we don't want to block the symptoms. To answer your question, Hamada, we don't want to block all the symptoms with benzodiazepine and not leave time for therapy and medications.
Okay. So we do have quite a few more questions.
Sure.
What are your thoughts on exposure-based treatments, whether it be for OCD or PTSD? So prolonged exposure therapy or exposure response and prevention therapy.
Yeah. I'm very interested in exposure therapy and treatment, especially for OCD. We have we actually invited an expert in Connecticut to tell us about that, and she's very good. I don't have the experience that myself, um, but I feel it's almost similar to me that to the EMDR with a different format. It's which is like revisiting these fearful stimuli, right? I believe in it. It's very helpful in OCD disorder. I really don't know if there's any work done with trauma or PTSD, but I feel like it. I support it very much.
And the next question, someone asked, which year was the book from Stahl published?
Um, that was 2021. I think so. There's like the big textbooks, but these that you mean that has that table?
Yeah, because I think they sent the question right after you shared the table.
Okay, I think I want to say 21 or 22. It's one of those illustrated books, and he put that table there. I can really follow up with an email, but I think it's 21 or 22.
And then someone asked, SSRI increases serotonin. Can you explain mechanism of action? It takes 4 to 6 weeks to take effects. Interim, do you start benzos?
Yes, I love SSRIs. Um, I really feel that they don't take that long to work. Um, um, After the 15 years of experience, I want to say that we can have a good response and or a good start in 2 weeks. Um, so the actual mechanism of action in details we don't know, but however, the serotonin pathway, regulating the serotonin pathway is the main issue that we found when we treat that people with anxiety and depression have. So we're regulating their serotonin pathway. So in a way, you can say if they're low, we're increasing it, and if there's too much, we're regulating it. So we give that person serotonin, it regulates the pathway, it adds more serotonin receptors in the brain. Um, so that's why in many of the antidepressants, we see an initial improvement within 1 or 2 days, and that's through taking those first few pills. So that almost like gives us that false, uh, it's a false impression that things are getting better, but also it's a good placebo people get. The most important thing I find it helpful in treatment is that hope, the initial hope. I went to that doctor, I went to that APRN, I went to that therapist, and they heard me, and I have hope that things will get better. So antidepressant usually in the first 2, 3 days give that boost, then they feel down again, almost what happened? I felt fine for a day or two. That's the initial taking it. That's increasing the serotonin in the blood, but that's not actually how they work. They regulate the receptors after 2 to 3 weeks. In the books, sometimes we read 4 to 6 weeks, but that's how they really work in helping them. Um, Anxiety disorder or benzodiazepines are really based on the function. When people are able to be okay, go to work, go to school, and they have just mild to moderate anxiety, I don't have to start with benzodiazepine. We can start with things like gabapentin or the beta blockers. But once they have panic attacks, and I'm sure you met your clients with panic attack, that's devastating. That makes them not able to function well. So I do start the benzodiazepines actually from day one if their function is not good.
Dr. Elsamra, in context to that question, do you
Yeah.
start the longer acting like clonazepam or shorter acting when you do have the panic attacks?
Yeah, most of the time I start with Valium, Klonopin or Valium. With exception, I give a lorazepam or Ativan. I never give Xanax because of the increased potential of abuse and because of the rapid onset and rapid coming down from it. So I actually don't use alprazolam at all, but I use Klonopin, Valium, and in a lower rate Ativan.
Now, if they don't respond to one SSRI, do you switch them to the second class? That's like in internal medicine, I see this all the time that they're not responding to one. How long should I wait to switch them to a different class? Like, okay, they don't go to fluoxetine, then you switch to another class? How long should you wait for?
I wait and I don't change the class right away. I'm a big believer that we will find an answer in an SSRI first. So I start with the commonly used medication like Zoloft or uh, even Prozac, and when I switch, if I don't see the response that I like after 2 to 3 weeks, I really start to think about the sedating SSRIs like Lexapro and Paxil. I feel like that's usually my second to go among that same class. Once I have 2 SSRI attempts and not even a partial improvement, then I definitely and I add the benzodiazepine. I add all these beta blockers and alpha and gabapentin and alpha 2 antagonists. After 2 medication, I feel like it's fair to change the class, and I go to the SNRIs. I would really choose the medication like the newer Prestige is I will always prefer it over the venlafaxine, which is Effexor. So the Prestige and the Cymbalta are always that will be my go-to as a second option after trying maybe 2 SSRIs.
Thank you.
Dr. Elsamra, just a quick question. Is there a reason you don't start with an SNRI as opposed to starting with an SSRI since it covers another neurotransmitter that's also implicated in anxiety disorder?
Yeah, that's a great question. So I think that's just like personal preference. I cannot say there's any scientific um, answer to that. I just have a great results with the SSRI, especially the sedating SSRI. Especially, we should also take a 2-3 minutes talk about teens. It's just I feel like I have great results with the SSRI first, and it's really just a clinical preference. I feel also when my clients have a more moderate or severe anxiety disorder, they tend to hyper focus on the side effects. And I do sometimes feel that other classes may have this exaggerated response in their head about the side effects. SNRIs are great medications, but I have a little bit more hesitancy of starting it due to the side effects as well.
And just a follow-up question, in terms of those patients who experience significant amount of side effects, sexual side effects pertaining to SSRI specifically, and even SNRIs, how about these new serotonin modulators, Trintellix, Vibrate, and some of these things?
Yes.
There's anecdotal stuff out there but in terms of their potency for actual depression and anxiety, what is your experience?
I like them. I definitely with the sexual side effects. I usually I still use the SSRI. I adjust the dose. I lower the dose. Um, I read a lot of education. I take a lot of time that things happen. The body will get used to it. Maybe with lowering the dose, but switching to Trintellix and Vibrate have also been very helpful in taking care of these symptoms. I was skeptical when they were promoted as such, um, and I understand that. I think both were not indicated still for anxiety disorder, like officially, but I did use Trintellix for depression and anxiety disorder, and they're working okay. Um, Definitely I always tell the people that they're the hardest to accept, even sometimes being on medications if they really have severe anxiety. And the last thing they want to do is the side effect. Um, I don't start with the Trintellix and the Vibrate, by the way. I really use them as a kind of second uh, tier SSRIs.
So going back to the questions we have here, someone asked, does including treatments tied to spirituality help with anxiety and depression, like using RCBT, which I think is religiously integrative CBT?
Absolutely. So spiritual based, religious based, I talk about religion with my patients, whether they're Muslims or non-Muslims. I really like to get them into getting a the connections, right? I think there's a lot of a non-spiritual treatment is working because it has the spiritual aspects. Good example is the AA meetings. It has a lot of spiritual action themes. It also has this kind of brotherhood, sisterhood feeling when you actually think about it. They meet weekly, at least. They ask about each other. They call each other every day. They touch base if they have problems. So when you think about it, it's almost like, without a doubt, it has a spiritual and religious background there. So I think pick and choose with your clients. I believe that communities like our community, Muslim community, that religion is part of their life. Absolutely, we should guide them to get the connection, at least the social support, at least the sense of community. I start not to ask them to get uh, a specialized treatment under an Islamic center, and I still want the clients to kind of separate that a little bit in terms of the CBT treatment or medication management, but absolutely being part of a community that they're comfortable with, part of a spiritual connection with people that they know and they feel comfortable with, is absolutely will be helpful for, especially the depression. Um, I have more results with the depression. Look, anxiety is not as such.
Jazakumullah khair.
Like,
Someone asked, should the diagnosis of panic disorder always be assigned with PTSD?
no, it doesn't have to. It doesn't have. Panic disorder, in a way, on the books, is very hard to diagnose. So somebody with PTSD can have a lot of panic attacks, but they don't meet the criteria. And at that point, you would diagnose the PTSD. It's easier, but they don't have to come together. Uh,
Could you discuss the effective medication options for OCD?
Yes. So I see sometimes, and I'm sure there's some colleagues here, I don't want to overstep or overspeak, but I see the SSRI class as like a continuum. One end of the continuum is hit hard, they're more hit different receptors, and they're kind of activating, right? What we call like the Prozac is the best model of that. And then the other continuum are the sedating SSRIs. And I like to choose those in the middle uh, for depression, anxiety. With 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 the OCD, my choices are always the Luvox and the Zoloft. I always start with the Zoloft. It's kind of almost like my golden medicine. And as a second I go for the older medication, fluvoxamine or the Luvox, and usually higher doses is recommended. I usually don't stop even if some improvement. I right away give benzodiazepines because of if they're dysfunctional. I People with OCD always ask about the uncomfortable obsessions that they will never share unless you ask about the violence, the aggression obsessions, the sexual obsessions, the very bizarre, wild obsession. Ask about them. You don't have to ask about them all the time, but it's better to ask about them, document it, and kind of try to kind of revisit every now and then based on the effect of medication. Higher doses always recommended with Zoloft and Luvox. Go to the 200, 250, sometimes even 300. And if there's mild side effect, separate the dose uh, with definitely benzodiazepines. So Zoloft and Luvox would be my choice for OCD. Adding a sorry, I need to say it. Adding a small dose of atypical antipsychotic is very helpful if we don't have a full response to the SSRI. Small doses of the D antagonists antipsychotic like the risperidone or the newer medication like Latuda or Exalti, which is a mix of agonist and agonist and antagonist, are helpful for the OCD symptoms as well.
Jazakallah khair. The next question was very similar, was asking about the to discuss the effective medication options for OCD, which we did.
Yeah.
Someone else said that they benefited from EMDR and occasionally used Klonopin, and that they were previously diagnosed with panic. Someone asked that they have a client with a diagnosis of depression and PTSD. Their question concerns their stiffness. They hold their body so tight. They've tried numerous body, mind, and mind to body without any success. They also have a history of failed back surgery. My question is, what else can they try?
Yeah. So that's a depression. Did that person mention depression and PTSD, Dr. Wafa?
Yes.
Okay, so that's to go back to actually the slides. That person with the stiffness will benefit from muscle relaxants or benefit from something like Lyrica. Lyrica for for any pain, muscle relaxants. I sometimes use baclofen as a muscle relaxant unless we have to rule out that these things are not side effects of medication. Of course, that's like the basic word, but focus on the body now. So the mood is maybe a little bit better. So maybe that person needs some relieve the muscle pain and the tension, and relieve the neuropathic pain with Lyrica and baclofen, especially to relax the muscles. Some of the benzodiazepines, as we all know, also have a muscle relaxing effect. The long-acting Klonopin can really relax the muscle as well. So with that person, focus on what to relieve their physical symptoms, focus on their body, and then because it seems like that maybe the mood disorder is 40-50% better. Let's try to get a push to improve the body as well.
Jazakallah khair. Someone said, what is more implicated in anxiety, serotonin or neuro? I think they misspelled.
Norepinephrine.
Yeah.
Serotonin and the GABA, GABA, which is why we give the benzodiazepine, the serotonin and the GABA, not the norepinephrine, in my opinion.
Someone said, I'm wondering if the presenter is familiar with dysautonomia, if the client has an anxiety disorder and a neurological problem from stress, would he advise on treatment with medication be the same as he described?
Heard that name, dysautonomia. Is that can finding words. Can you help me with?
The dysautonomia is when you have autonomic dysfunction, like a small fiber
This
dysfunction.
autonomic.
More
Okay.
likely to get dizziness and orthostatic hypotension. By the way, that's not my question. I'm just kind of helping.
Yeah,
Okay.
that
I
was my
didn't hear
question,
what.
and exactly, yeah.
Okay. Okay.
Probably, I mean, you can speak for yourself. I think that was Masuma. But I think probably what's implied is that you're more likely to have orthostatic hypotension and those type of side effects with dysautonomia.
Yeah. So I mean, I don't want to just gonna be boring. Rule out the medical part. Rule out dehydration. But if you feel like the anxiety symptoms is connected with it, absolutely. This is a person you measure the blood pressure, you measure the heart rate, and see what's missing there. Definitely need kind of some work, lab work as well. Right, Hamada, do you want to add something here?
Yeah, you have to. I mean, it's kind of like when you have these more complex niche issues, you have to start low with medication and go slowly. And SNRIs might be helpful, but you have to be very careful. And dysautonomia, it depends on what's causing it. If it's more dominant, the orthostatic hypertension, if it's the heart rate variability, it could be a number of different things. You'd avoid beta blockers, for instance.
Okay, of course, yeah. If the heart, yeah, you definitely want to rule out dehydration. If that person, Masuma is your name. If that person is on medication, I have many incidents of the hypersensitivity on the taking the medication different times of the day that can cause this autonomic dysregulation, especially actually with people with who are taking medication, especially with things like SNRIs. So rule that out. But if that person doesn't take any medication, so yeah, it's start small and rule out any medical issues and get if you work with the APRN. I don't know your degree, but get the primary care on board.
Yeah, so I'm angling it from the family systems and medical family therapy point of view. So these are clients that have medical complexity, and then and then they also have like a mood disorder, and anxiety is really common with it. So they have a cardiologist, they have a neurologist, they're getting all those medications, and they have that follow-up.
Yeah.
But then they're
Wow.
trying to live with it, and it's their body that makes them feel anxious to begin with.
Correct.
But they also have, like they need to break down their like thought processes around anxiety, including anxiety about their body, but also other things. And so I'm doing more of the talk therapy part, but I'm just curious it made me really curious what you were saying about like Lyrica and medications that can actually treat pain if addressing something in the body through that angle might help patients like this.
Yeah. One thing I also sometimes I do, and I find it helpful, but almost like it's a test. Like if that person is not on, let's say, not on any benzodiazepines, and you have a feeling that these symptoms are strongly connected with anxiety, there's no harm from using a Klonopin, let's say, for a week or two, and then actually go day to day and ask that person to monitor the symptoms, right? And I tell that person, listen, what we're doing now is you wake up in the morning, you block these anxiety. So we know that this medication treats anxiety. Let's see what left from these symptoms. Are they related to the anxiety? Because we might learn that these symptoms are separate. They're maybe more physical. There's more maybe more side effects of other medications. So we don't know. So having a medication like benzodiazepine for a week or two to rule out if these symptoms are connected to anxiety or not as well.
Thank you.
And also there was a follow-up to that question. Do you see a difference in the MENA community responses to medications to treating anxiety? Since MENA American population is a trauma-heavy community and also is not the ethnic population drugs were developed for.
I think the only thing that complicates the treatment. The way I want to see it is the cannabis use, in my opinion, whether it's the for all the background, the MENA population or different ethnicities. I feel like when they are the younger, not the younger, but I feel like when they're committed to treatment, the results are amazing. They're very good. The new immigrant population, they're heavy in trauma, but they're not culturally. Some of them are not committed to long-term treatment, but when they are, they have great results.
Jazakallah khair. I know we are approaching the end of time. There were a few more questions,
Let's take
but
two more,
okay, sounds good.
if that's okay with you.
Yeah. Someone asked, how do you educate younger patients or any patients who are using cannabis as self-medicating from generalized anxiety and panic?
Yeah, yeah. Do you have another hour? Hamada knows my favorite subjects in this. It's a long subject. That's a long subject. I'm fully against that because of the destructive outcome that I see. I take it slowly. I meet in the middle. I do all what we do, right? That we listen, and I challenge, right, through the motivational interviewing. I really challenge it. I challenge it gently first, and then when things escalate, and then I say, as simple as, well, listen, things are getting worse, and almost these keep changing one medication to another, and the anxiety disorder or little suspiciousness and paranoia keep there. I say things, they don't work more than half of the time, but I say, you owe this to yourself. Why not try not to smoke for 6 months? And if you feel like things didn't change, go back to smoke. Nothing will happen. You're trying to take a temporary relief to protect yourself from that external factor. So it's a hard work, but this is across the board, all ethnicities. I'm sure we all face it. That is acceptable. It's socially cool and socially acceptable, and it's available. So it's a harder work, but it's doable.
Jazakallah khair. And then someone asked that or mentioned that they missed the introduction part of the presentation. Would you be able to share what you mean by all in our head?
I think the all in our head, all in our head was as trying to be funny. But it's a statement that my patients say a lot about saying the symptom, sometimes the mental, sometimes the physical, and they're all correct about it. They're really very connected. The mental symptoms, the behavioral symptoms, I call it the front end and the back end, right? The front end of the behavioral and the depression and anxiety and the mood disorder, but it's all originating from the back end, which is all in our head. But most importantly, the objective of this was really how to link all this also to the physiological, why we really should measure the blood pressure and the heart rate and check the labs and connection to this complex physiological system. So that's what I meant by all in the head, that the brain, the amazing complexity that affect our behavioral symptoms, but also affect our physiological system. So that's what I meant.
Jazakumullah khair. And someone asked if you can give a cannabis use talk in the future, inshallah.
I did it 2 years ago, Hamada, right? Yeah, I can combine it with other more interesting, maybe substance use. But yes, if it's needed, I'm happy to.
And members have access to the old videos too.
Okay.
Yes, which takes us into how to become a member. So if you all are interested in becoming an Institute of Muslim Mental Health member and to have access to recordings of old webinars, and to just, keep on top of everything that we're doing as an institute, feel free to become a member. And to become a member, you would, I put the link in the chat. There's a student fee, and a professional fee. So depending on how you identify, you can choose either one, inshallah. And if you all have any suggestions or ideas for future talks that you would like to hear or any feedback for us, please complete the feedback form that was sent out earlier. And Jazakumullah khair, Dr. Mohamed Elsamra, for sharing with us and answering all these questions that people asked. So we really, really appreciate your time and in
Absolutely.
Ramadan as well.
And I put my email on the slide. Feel free
Yeah, of
really
course.
to email me. Anyone take the email, and feel free to email me if you have any questions, any directive, any suggestions. I'm happy to hear from you.
Jazakumullah khair.
All right, everybody.
Jazakallah khair. Thanks, Mohammed.
Assalamu alaikum. Take care.
Wassalam.
Wa alaikum assalam.